Good morning, everyone. This is our live Q&A call for August 24th, 2015. This is Kathy Randall, and I am coming to you from outside my favorite place. Like probably most of you, I'm sitting in front of Starbucks. I'm actually out and about on the road, so I didn't want to miss our Q&A call, but I just wanted to say good morning and just say thanks for joining us today. So we're going to take a little dive this morning into some cases of the month. So case of the month is a service that is included when you have taken the aEEG course, and it's available for, we do one every month. And then if you're a member of our ongoing support community, then Case of the Month is also included, as well as these Q&A calls. So I'm going to turn my camera off. I just wanted to say good morning and hello. But I'm going to turn that off because I'm not ever sure if the audio is in sync. So let's dive right in. So when we think about doing aEEG classification and interpretation, these are the 6 things that we look at when we're looking at the actual aEEG pattern and monitors. So we look at background, the presence for sleep, the presence of symmetry, whether or not it's stable over time. We look for presence of seizures, and then artifacts that might be looking like seizures. The thing that's actually missing from this list, which I think is important as you even prepare to go do your aEEG review, is the baby and the baby's story. And what is the baby's history, and what do you expect to see here when you walk up to the monitor. So we're going to go through all of the aEEG tracings and cases that are currently up on the website, and that is going to be our review for today. So we're going to start with case number 1. So this is a baby who had a precipitous delivery at term, and APGARs were 3 and 5. Baby had CPR for 1 minute, intubated at 38 minutes of life due to a poor respiratory effort, transferred to the NICU with a acidotic gas. Hypothermia was started at 3 hours of life. The baby's exam at 12 hours showed fixed and dilated pupils. There was a suspicious clinical event at 18 hours in which the baby then received phenobarb of 20 mg per kg. And then aEEG monitoring began at 20 hours of life. So at basically 22 hours of life, because we can see that there's about a 2-hour tracing here, this is what we have. And I think, again, remembering back, this is a term baby, we want to think whether or not this is the type of aEEG pattern we expect for this baby's age. And then if we say, well, this is a term baby, so I would expect a continuously normal voltage pattern, but I don't see that, then we start to think, is this a pattern that I would potentially expect based on the baby's history? So again, maybe not what we would expect for a healthy baby, but definitely a baby who's had a difficult time transitioning, as well as potentially had a seizure and received phenobarb. This is not such a horrible looking trace. So first off, we want to talk about what is this background pattern. So again, we always assess the upper and the lower margins, and I wish that I had the cross-cerebral, but I don't. So we're going to look at this bilateral aEEG tracing. So what is this background pattern of these bilaterals? Well, we know that the upper margin is above 10, and we see that the lower margin is below 5. It's a rather thick-looking band. And so it's a pretty classic-looking discontinuous pattern. So if we compare the pattern left and right, we see that it is symmetrical. We look for sleep-wake cycling. We don't really see any of that really nice thin, thick alternating pattern about once an hour. We don't see that. And then we're looking for seizures. So I don't see any areas that are, for me, suspicious of seizures, but certainly there are some areas that are changing at the bottom margin that if you wanted to look at, but certainly not that abrupt kind of upper and lower margin shift, that archway in our pattern. And then the last question is it consistent with the clinical picture? So fixed and dilated pupils requiring mechanical ventilation. I mean, for me, this pattern is consistent with a baby who's received phenobarbital, right? So you're going to give phenobarbital, going to kind of mellow out the brain, going to quiet some activity, which is going to put you in a discontinuous pattern. Oftentimes, though, for phenobarb loading doses, especially only one loading dose of 20, I wouldn't expect that if this baby had a normal background that it might suppress it for 30 or 40 minutes, but then I would maybe want to see a better return to baseline after that dose. So anyways, we're kind of here at this 20 to 24-hour mark, and we're seeing a discontinuous pattern. Obviously, a baby who has fixed and dilated pupils requiring mechanical ventilation, certainly I wouldn't have been that surprised if the pattern was way worse. So in some ways, I'm kind of happy with what I see. So here is the repeat of that baby on day 8. So again, looking at the background pattern, we now notice that the lower margin is greater than, or at least approaching 5, and then the upper margin is still greater than 10. And then we see a little bit of this beginning, at least in this pattern. It's a little messy, right? But if we kind of go straight up from where you see the exit review yellow box, and you kind of go up, right there you see a little bit of a thickening, and then it lasts for about 30 minutes, and then you see a thinning and a rising up of that bottom margin to a more normal voltage, and then maybe another attempt at a sleep cycling kind of near the right side. So I'm kind of happy with this. I would say it's a normal voltage pattern. I'm beginning to see sleep-wake cycling, and I don't really see any areas that are overly concerning for seizures. And of course, it is at 1 week of life, so I would have liked to have seen this for a cooling baby. We'd like to see that return of normal pattern, as quickly as possible. But remember, his tracing at 24 hours of life was only discontinuous. And for cooling babies, a discontinuous or a continuous normal tracing is a good prognostic indicator for a good long-term outcome. So although it's not beautiful by any means, I'm happy to see that it's more sleep-wake cycling, and for me, this is a very suggestive of a positive turn and a positive outcome. All right, so moving on to case number 2. So vacuum-assisted delivery, term baby. This is a bath bars were 3 and 7, and a umbilical cord gas returns with low pH. So acidotic baby. The baby is non-responsive. There's requirement for ongoing ventilatory support. There's a documented seizure, and the baby was also given a loading dose of 20 per kilo, and you monitor the baby for 3 hours. So, what do you think of this tracing? So again, remembering it's a term baby, remembering he's received a dose of phenobarb, and then really looking to see what did I expect to see for a baby this age, what did I expect to see for a baby with this kind of clinical acute situation going on, and am I assured or disappointed or concerned by what I see? So first off is, what is the background pattern? Well, the background pattern itself is rather low voltage, almost flat, and there is no sleep-wake cycling, but there are some alternating areas of increased voltage throughout this pattern. Those increases are not sleep-wake. Those are very likely to be seizures. And for me, this baby is in status epilepticus. And for this baby, unfortunately, it is actually quite consistent with what we've seen for his clinical picture. So what would you do next? So if this was in your unit, a baby came in, he's just a few hours of age, let's say, what would you do for this baby? Would you cool him? That would be one thing, right? Would you maybe get a neurology consult? Would you get an MRI? Would you talk to the family? So these are all questions. With aEEG, it's just an assessment. It's just information. And then what you choose to do with this and then how you choose to treat the baby is really up to you. And there is, of course, no right and wrong. It is, with taking all into consideration. But certainly at 24 hours of age, this is a very worrisome trace, very injured brain. And if the baby was just admitted at 24 hours, maybe the baby was out at an outlying facility, it's unfortunate right now this is too late to start cooling. And so you would have to do other things. And although there are many medications that are being investigated to potentially help rescue brains at this age, there's nothing currently clinically available. So again, just it's one more piece to our puzzle, and then you can go from there. All right, so let's look at case number 3. So again, aEEG case of the month. These are things that are available to people who have participated in the online course as well as the online community. So this is case number 3 that is currently up on the website. So term baby underwent emergency C-section for fetal distress. APGARs were 1, 3, 3, 6, and 7. Baby was intubated, chest compressions, and had epi times 3, and the first pH off the baby is 6.27. First breath was taken at 22 minutes, and the first clinical seizure was noted at 45 minutes. Cooling was begun, and monitoring began at 9 hours. So again, hypothermia began at 4.5 hours of life, and then the monitoring began at 9. So definitely, I'm giving this baby everything we've got. So again, term baby, let's think about what's the pattern we expect. Then let's think of the clinical scenario, and then let's look at the tracing. So in this particular tracing, again, we're looking at the aEEG upper and lower margins, and we see that there is a very, very flat tracing. So if the baby is being cooled and the baby is 24 hours of age, what do we need to do? Number one, we need to continue monitoring, right? We need to keep continuously monitoring. We maybe, if we don't already have full video EEG, we might want to consider getting that. Although really at this point, it may not be able to add that much more. And then the other thing about this pattern, and especially patterns of babies during cooling, is to think about the age. And although this is a very, very poor trace, a pathological tracing, we want to be reserving judgment for these cooling babies until we at least reach that 48 hours. So we know that they can have some significant changes. We know that depending on what other things might be going on with the baby, maybe his blood pressure, maybe his other cerebral perfusion, we want to just reserve judgment until we get past that 48 hours, because we know that babies need longer, especially cooling babies, to recover that background. So we still want to be looking for symmetry. And certainly if this could indicate if there was a unilateral insult or stroke, we'd want to know that. We'd also definitely want to keep monitoring background pattern and look for any evidence of seizures, which at this point I don't see any areas that are worrisome. I just see nothing but worrisome background because there's just such a low voltage. And then what would we do next for this baby? I've already kind of talked about it. Number one, I think, is continue monitoring and continuing to be hyper vigilant around background and the reemergence of any cycling, as well as the emergence of seizures. So again, this is very early on. It is a poor tracing, a very pathological tracing, but because we're cooling the baby, we want to reserve judgment. So again, baby's just 24 hours of age. So we want to just hold on to that until we know a little bit more. All right, so let's dive into case number 4. So this is a term baby. Boy, these are all term babies so far. Term babies, good APGARs, no resuscitation required, went home with parents at 48 hours of life. On day 7, baby became increasingly lethargic, had a seizure, focal clonic seizure noted by the parents. probably recorded on their iPhone, right? Admitted to the NICU, and monitoring began within 2 hours of admission. So here is our aEEG recording that we saw. So we have a baby who has been now monitored for 3 hours, and we see that the background pattern is symmetrical. We see that the upper margins on both sides are greater than 10, and we see that the lower margin is, sorry, car is crazy loud. The lower margin is less than 5, upper margin greater than 10, and it is symmetrical. We don't see any sleep-wake cycling, but we do see something super suspicious right in the middle, right? So we all see that, and somebody else saw it too, and they opened up this tracing and took a snapshot, and we see this very, very consistent spike wave pattern originating from the right side. So when we are looking at this, again, we're asking ourselves always the same question. First off, baby's story. What do I expect to see for age? And then looking and assessing that background pattern. So upper margin greater than 10, lower margin less than 5. So for a term baby, not what I'm expecting, especially not a baby who's a week old. It is symmetrical, so that's reassuring in the sense the background pattern is symmetrical. I don't see sleep-wake cycling, which I would expect to see for a baby this age, so if that's making me worried. Are there any artifacts or seizures? I believe there are seizures. I don't see any artifacts. What does the background pattern suggest of the overall brain condition? Well, again, term baby, week of life, no sleep-wake cycling, discontinuous pattern. Something's definitely suppressing this baby's brain activity. And we obviously have a unilaterally based seizure. Certainly we're only looking at 2 channels of aEEG, so we can't know for sure whether or not there are other focal seizures occurring or if this seizure is generalizing out to other areas. But certainly we know from this channel we can see that we have a seizure. So what is the cause of the seizure? That's for our workup to continue to discover, but certainly a seizure is never, especially an electrographic seizure, very worrisome. Time to look for that cause and hopefully get this under control. Alrighty, so here is case number 5 of aEEG case of the month, and we've got our history of a term baby with a normal delivery and discharged home well, and presented with seizures on the 4th day of life with a rash. Doesn't sound good, right? aEEG began after the arrival to the NICU. So here we go. Here's our aEEG pattern. So we have a 2-channel aEEG. We have our left and right EEG at the top. We have our left and right aEEG at the bottom. And we have about 3.5-hour tracing here. So first thing, always thinking about, again, the baby's age. So the baby's a term baby. Baby's coming in with seizure. And we're wondering, and a rash, remember? So this is, we're worried about this kiddo. So we've got here this background pattern. So again, we're just always going to go through those simple things. We know what the baby's age is, so we know what kind of pattern we would expect. And this pattern is a little challenging because I believe if you start at the left margin and you move kind of over for about an hour, hour and a half, I believe that you're seeing some seizure activity there for the first hour, hour and a half, and then the pattern resumes a little bit more of an uninterrupted place. So I would say for looking at the background pattern, I would probably ignore the first couple hours and look maybe from midpoint at 1300 and beyond. So at that point, you've got bottom margins greater than 5, upper margins greater than 10. You've got this cyclic pattern going thin and then thick and then thin again. And really, honestly, both the left and the right side of the brain look pretty similar and almost synchronous to some degree. They're moving in and out of these cycles. So with that said, the background pattern is quite normal, and for age, this is what we would expect. The problem, really, with this tracing is that first half that we see on the left side of the margin. And we see quite a few concerning areas of potential for seizure. So let's go through our questions. So background pattern, normal, continuous normal voltage with sleep-wake cycling, which is really great. Just based on the background pattern alone, we're not really that concerned about the baby's overall health. The problem is that we get this beginning part of the tracing that is indicative of seizures. And it's not just one seizure, but it's an almost 45 minute to an hour period where there is constant seizures. And that would be still classified as status epilepticus. So it's a 30-minute period where there is not really a return to baseline, not a return to that normal tracing. It is almost continuously for an hour going in and out of seizures. So again, this baby has a rash. So what are some of the diagnoses that are coming up in your mind as what might be causing this? Some sort of viral encephalitis of some sort of, is it bacterial? So what's really going through your mind, and what are going to be the next steps for this baby? As far as aEEG monitoring goes, I would continue to at least monitor with aEEG. I think with this very suspicious pattern of seizures, I would probably assume that if it's some sort of viral something going on, and we're talking about a viral meningitis, then we really probably want to get neurology involved if we could get full video EEG, because certainly this is going to be a type of an injury or dysfunction in the brain that is more diffuse and global, and we wouldn't want to miss out on any of those seizures. So I would probably opt for more monitoring if I could get it. If not, at a minimum, I would keep this up. Of course, do all your standard workups and cultures and isolate and treat. So anything else? Any other ideas? Of course, you always can comment on these on Facebook and, of course, in the forum as well. All right, case number 6. Term baby girl born via crash C-section with prolapse. Sorry, let's start from the top again, right? It's like tongue-tied. So, term baby, crash C-section, APGARs 1, 2, 4, and 6. Cord gas, acidotic. Seizures noted at 20 minutes of age. Loaded again with phenobarbital. In the United States, that is our go-to number one. Transferred from another hospital to our hospital for therapeutic hypothermia, was randomized actually to 120 hours of cooling at kind of our standard, but this is a prolonged cooling case. So, on admission, term baby, first day of life, initiating hypothermia, this is what we see. So, background pattern, expected for age, no. Expected for condition, yes. And do we see any seizures or suspicious areas? So I don't know about you, but I kind of see as we start moving towards the right margin, this pattern's very, very flat tracing with occasional spikes, but I would call it mostly a flat tracing. And maybe around that last hour or so, it starts to get more density to the band, starts to become more continuous, but it is still very low voltage. And there's a very odd something in the last kind of 20 minutes here where you have that uprising in a flattened area that's on the left side. And it's very suspicious. So whether or not it's seizures, I don't know, but it is suspicious. And if I was standing in front of this monitor, I would definitely open up that area because this is a baby who I'm very worried might be having seizures. So let's look on. This is the next day. So this is still a term baby, and we are just 24 hours of life in the midst of cooling. And what is the background pattern now? So it's not completely thick, where I would say completely dense, where it would be that continuous low voltage. The upper margin is not quite reaching 25, so I don't want to really call it burst depression. It's not really continuous. It's just extremely, especially on the left half from the red line over to the left, I would say that's excessive discontinuity, excessive low voltage. And then as we get moving towards the right side, it's becoming a denser pattern. And what's interesting about this baby is that they have had lots of jittery spells. So hypothermia babies, these are so complicated sometimes, right? We have babies who are jittery, babies who are shivering, and it's sometimes hard to tell the difference. And the thing we can then use aEEG is to almost kind of break the tie of, like, is it jittery, is it seizures? I don't know. You know, you can kind of go back and forth around with your colleagues. But using aEEG, you can oftentimes just get a little more evidence to see if you can decide whether or not what you're seeing is worth treating. So on this particular snapshot, although we see lots of disruptions of the baseline and could very well be status epilepticus, when we open it up, we just see a lot of fuzziness. We see more likely to be muscle artifacts and some other external artifacts. So not really thinking this is seizures at this point, although clinically people are very concerned. This is day 2 of life. We can look at the background pattern now. You can see that the density or the thickness of the pen strokes are becoming much stronger. This is really becoming that continuous low voltage. So its upper margin is less than 10, lower margin less than 5, but the density of the pattern is what's really telling us that this is continuously having activity. And there are these very low voltage changes at the bottom margin that are disrupting the aEEG band. And it's concerning for us. And the nurse is continuing to tell us that there is jerking movement. And so we're trying to start to put things together. You know, is this baby actually clinically seizing, or are we, are we just seeing, jittery movements and maybe shivering or something, or agitation? So in this particular case, we see that the aEEG pattern is improving in the sense of it's more continuous. So even though it's not normal voltage continuous, it's more continuous activity than we had before. But we do see these disruptions, and then when we look, the disruptions of the aEEG margin, and when we look at the actual upper margin, we do see, or the actual EEG, so we look at the upper half of the screen, we see that there is this rhythmic pattern that's breaking through. So it is making us suspicious for seizures and likely need to treat. So this is 24 hours later, still seeing this clinical movement. And what do you think about this aEEG background now? It's still thin as far as our aEEG, as in the bandwidth is narrow. It is still continuous, so it has that density to it. It's starting to shift upwards a bit, meaning that there's more activity for longer periods of time. So we're seeing that bottom margin lift upwards towards the 5. But there is no sleep-wake pattern, and there's almost no variability. So even though the lower margin is moving upwards, we can see that it's just like when we think of heart rate variability, right? There should be heart rate variability, but there's just not. And this is worrisome to me that it's just so consistent. And then there are a couple areas where we see these uprisings, and then when we open up the EEG in a couple of these spots, we actually do see that there is some spike wave patterns happening that are repetitive. So I do believe there's evidence of seizures on this particular baby that are still going on. And remember, this was a baby who was getting cooled for many days. This is 120 hours of life. So this is a concerning tracing. Even though the margins are improving, I also see a lot of kind of the EEG. The EEG is kind of rough and scribbly, scruffy almost. And I think that's contributing, as well as these seizures are contributing to the bottom margin being up a little. So the baby that night continued to have jerking movements, and people were just really concerned, and they gave one dose of Ativan around 1 in the morning. So you can see that the pattern was drastically affected by that dose of Ativan. And anytime we give these medications to premature babies or to babies who have brain injuries, so this is a baby with HIE who's undergoing cooling, very often we see really dramatic impacts on these medications. And you can see that in this case, we had a pretty dramatic effect. Went from kind of a discontinuous pattern to pretty much a burst suppression pattern, where you start seeing that lower margin flattens out. We see, spikes that are getting up to about 25, and we see that sparsity and kind of that density change in our aEEG. So it is difficult. We don't have the video on this baby, but certainly continuing to have jerking movements, still having some of those breakthrough areas that we saw earlier in the day. So people decided to see if giving Ativan might give a help. Well, it certainly calms the brain down, right? But whether or not it actually treats the seizures, I don't really see any on the aEEG to the left, but certainly they thought clinically the baby was seizing. So this particular case doesn't have such a great outcome, although the baby did get hypothermia treatment. If we remember back, the beginning aEEG was very, very, very low and kind of persisted that way for the entire time. The baby was has hypotonia, was extubated in room air, but had no gag and no swallow. And then we got an MRI. And you can see that this baby has, in addition to having HIE, has also suffered a stroke. And this area is of great concern for the baby's long-term outcome. And so what the parents decided to do with the information that was provided by the clinical team, they decided to opt for comfort care, and they discussed the baby's clinical situation. And the baby went home on palliative comfort care and died at home with the parents. So although a sad outcome, you can see that aEEG really helps to tell that story along the way, as well as helps to inform us about what was going on. What I find interesting is that if we go back after kind of knowing what we know, a lot of times seizures were kind of more on that left side anyway. So I think it's interesting that once we had the MRI, it became much more clear that that was happening and had a real good reason. All right, so our final case, number 7. This is going to be a term baby with afterbirth of 8 and 9, no resuscitation required, and developing clinical seizures at 6 hours of age. So, term baby, 6 hours of age, what would we expect to see for his aEEG? Well, of course, we would expect to see a continuous normal voltage pattern with sleep-wake cycling. So, this baby, what did we see? We saw, well, I'll let you look for a little minute. So remember, we've got left side, right side, right side. And we want to look at that upper and lower margin of our aEEG band. And we want to look at it for both the left and the right. Well, in this case, if we look at the left, we can see that the aEEG band is less than 10 for most of the time and almost flat at times, definitely under 5 for a large period. That's on the left side. Then on the right side, we see that the upper margin is greater than 10, and we see that the lower margin is greater than 5. And then we see this kind of cyclic pattern going up, down, up, down, up, down, almost once an hour. And I don't see any areas that are really suspicious for seizures, but I certainly see that there is an asymmetry to the background pattern. So this particular tracing is really interesting because kind of on first visual look, I think that the sleep-wake patterns a little bit fake you out because you kind of think that there is this thin, thick, but if you really look at the left, you'll see that that lower margin has almost no variability. It's really only the upper margin that has variability, and it is synchronous in the sense of the left and the right are definitely acting similarly, and that there's definitely this effect of this cycling happening every hour, but the actual voltage pattern is different. As far as seizures, I don't see any. As far as artifacts, I don't see any on this EEG, but I certainly do see an asymmetrical pattern. In a term baby, the right side is what I would expect. The left side, not so much. So interestingly enough, on exam, the asymmetrical tone was not really evident. And you might think, oh, well, I see this asymmetrical aEEG. I might see asymmetrical tone. I might see something going on. So what are the diagnoses for this kid? Well, obviously, I think we're probably all thinking it, probably stroke. But remember, we talked about there are several other ways or other causes of the asymmetry. So we want to think about, just going back to the bedside, reassessing, is there fluid? Are the electrodes too close? Could there be some other cause of this asymmetry? And of course, it could be brain injury as well. And so we would either potentially want to get a full video EEG or maybe some imaging. We chose to get imaging, and we definitely confirmed there was left hemisphere injury. You can see it here as the white area on this MRI and diffusion in a DWI or diffusion-weighted imaging scan. So anyway, so for this particular kiddo, we want to think about, what are the things we want to talk to the family about? Is there a need to even continue the monitoring now that we have the diagnosis? Would you continue to monitor? These babies are very high risk for seizures, so I would definitely continue monitoring for at least 24 hours and be sure that there's not going to be anything else going on. These are complicated kids. You get your aEEG on. You see this asymmetrical aEEG. You take them off for MRI, and then you come back to the unit, and you probably had to take off all of your electrodes before you went to MRI. And so the staff are going to ask, is this a kid that we need to monitor? Do we need to keep going? And so I think there is enough evidence that these kids are at risk for seizures that I would certainly advocate for it. And I know it's an extra work, especially if they just put them on overnight and now you've taken them off. But I think there's certainly enough evidence. And you could consult with your neurology team if you have access to them and see if you want to just do full video EEG. But these are kids that definitely need monitoring, and I think they're worth it. So, all right, so those were our 6 or 7 cases that we've done so far this year, and I hope that you've enjoyed kind of reviewing them and going through them. I'd love to see you post in Facebook and in the forum if you've got questions, concerns, if you agree, if you disagree, if you've got ideas of things that you might have done different. Obviously, this is here to support you and to educate you and to get you thinking and to just reinforce your skills that you've learned through participating in our course as well as for being just a member of our aEEG community. So with that, I will leave you and remind you that our next live Q&A call is on Monday, September the 21st. It's a little bit early because I think many of you are traveling to Ireland to participate in the Brain Monitoring Conference this year in Cork, Ireland. So I didn't want to interfere with any extra vacation travel plans and give everyone the potential to be on the call. So our next live Q&A call will be September 21st, and thank you so much for being with us today.